Hello, everyone. Today we'll be discussing factitious disorders and why they matter to us in EMS. Factitious disorders, also commonly known as Munchausen syndrome and Munchausen by proxy, involve patients who intentionally fake or induce medical problems in themselves or others. This might sound rare or like something out of a movie, but it's a real challenge that EMTs and paramedics can encounter. Our goal in this session is to understand what these disorders are, how to spot red flags in the field, and how to respond professionally and safely. By the end, you should recognize common patterns of factitious disorder imposed on self and on another, and know how to handle these situations in an EMS context. Let's start with a basic definition. Factitious disorder is a mental health condition where a person deliberately produces or lies about medical symptoms without any obvious external benefit. In other words, they want to be seen as sick. This is different from something like malingering. For example, faking an illness to get out of work or to win a lawsuit is malingering, which has a clear external reward. In factitious disorder, the motivation is internal, often a deep seated need for attention or sympathy. There's no tangible payoff like money or avoiding jail. Instead, the process of receiving care fulfills a psychological need. Now, as EMS professionals, why do we care? Because even though it's uncommon, we might be the first to pick up on the clues. We get called to these patients' homes or scenes repeatedly. We see patterns that others might not, especially if the patient has been doctor hopping. Recognizing a possible factitious case can ultimately protect the patient from harm, or, in proxy cases, protect a child from abuse. So it's important for us to know the signs and handle these calls carefully. First, Munchausen syndrome, officially factitious disorder imposed on self. Here, the person is themselves the patient, and they're intentionally causing or faking symptoms. For example, a person might take a bunch of insulin to make themselves hypoglycemic, or put a drop of blood in their urine sample to fake a kidney problem. They might even injure themselves or take dangerous substances to create real symptoms. The key is they know they're deceiving healthcare providers, but they might not fully understand why they're driven to do it. What are some characteristics of someone with Munchausen? Often they're very knowledgeable about medical details and terminology. They've done their homework. They can present symptoms in a very convincing way, even mimicking complex medical conditions. You might notice they have a long history of hospital visits and are willing to undergo painful or risky procedures. In fact, they may seem oddly enthusiastic about tests or surgeries that most patients would want to avoid. This is because their goal is to remain in the patient role. Another point, there's no obvious external gain. They're not getting money or avoiding responsibilities. In fact, they often inconvenience themselves greatly. This is a psychological compulsion. Many have underlying issues, perhaps a history of trauma, low self esteem, or personality disorders, and they find a sense of identity in being sick. It's sad because it is a form of self harm and mental illness. Next, the by proxy type, which we now call factitious disorder imposed on another. This is the disturbing scenario where someone, usually a caregiver, fabricates or induces illness in a person under their care. The classic example is a parent, often the mother, harming her child to get attention. The caregiver gets to be the heroic mom or dad, always rushing to the hospital, and they soak up sympathy from medical staff, family, and community. Meanwhile, the child undergoes needless suffering. This is absolutely a form of abuse, essentially medical child abuse. In Munchausen by proxy, MBP, the perpetrator might do things like secretly giving the child substances to make them ill, or simply lying about symptoms like saying the child had a seizure when they did not. They then repeatedly bring the child in for medical care. Because the caregiver appears so devoted and concerned, it can initially fool providers. But over time, patterns emerge. It's often a vigilant EMS or ER team that starts suspecting something isn't right. We should note, MBP most often involves a parent and young child, but it could also be any caregiver. For example, an adult child caring for an elderly parent and falsifying their health issues. In all cases, it's serious abuse. Children have died in these situations, and many have long-term disabilities from unnecessary treatments. As EMS, if we suspect this, we have a duty to ensure it's escalated, meaning we report it so the child can be protected. We'll talk more about how to handle that, but just know MBP is both a psychiatric issue and a criminal act, child abuse at the same time. It's important to differentiate factitious disorders from malingering. In malingering, the patient fakes illness for obvious external gains, like avoiding work, getting drugs, or legal benefits. In factitious disorder, the goal is internal, a psychological need to be cared for. Both involve deception, but the motivations differ greatly. We don't need to confirm which is which in the field, but understanding this difference helps guide our empathy and documentation. So, how can we spot a possible factitious disorder? There are a number of red flags. One big one is when the symptoms are inconsistent. The patient's complaints might be vague or don't match the objective findings. For example, they claim to have severe neurological symptoms, but the exam doesn't align with that, or symptoms that seem to defy medical logic, getting worse without explanation or not responding at all to treatments that should help. That leads to another sign. These patients often don't improve as expected. If someone truly has, say, asthma, you'd expect some relief after an albuterol treatment. In a factitious case, the asthma might mysteriously persist or even worsen despite appropriate care because the symptoms are being manufactured. Another clue is an extensive medical history with multiple hospitals. You might find out this patient was just at another ER last week and another the week before, often using different names or stories. They tend to jump from provider to provider to avoid being found out. They also might have unusually deep medical knowledge. They can recite textbook details about diseases, sometimes even using medical jargon when talking to EMS, almost like they're reciting a script. Most laypersons don't do that. You might notice the patient seems oddly eager for interventions. They may actually request invasive procedures or seem excited about getting a workup. A normal patient might fear a surgery, a Munchausen patient might almost welcome it, since it validates their sick role. Over time, these individuals often accrue many surgical scars or marks from procedures. If you see a patient with a baffling number of old surgical scars or a history of repeated surgeries, and their current story is suspicious, it could be a clue. Also, pay attention to how they interact regarding their medical information. Often, factitious patients are protective of their medical narrative. They might avoid letting you speak to family or existing doctors who know them. They prefer to be the sole source of information. They may even become defensive or argumentative if you ask too many questions, or if a doctor questions their story. And a small telltale sign. These patients often have few visitors or support people when hospitalized, perhaps because they've burned bridges or because their family might suspect something. It's not a definitive sign by itself, but in context, it adds to the picture. Now, when dealing with factitious disorder by proxy cases, we have some extra red flags to watch for involving the caregiver child dynamic. One classic sign: the child's condition or symptoms only occur in the presence of the caregiver. For instance, EMS is called for a child who was reportedly blue and not breathing, but when you arrive, the child is pink and crying, and only the mother witnessed the apnea. If this happens repeatedly, that's a huge warning. Similarly, the child might get better in the hospital when away from the caregiver, and then worsen again as soon as they're back with them. That pattern is very suspicious. The caregiver's behavior might also raise flags. A lot of times, an MBP perpetrator is overly involved with medical staff. They may be extremely friendly, almost to the point of trying to be part of the team, or they may be unusually calm in situations that would terrify most parents. Imagine a parent who is not as panicked as you'd expect when their child is severely ill. Instead, they're oddly composed or even seem to enjoy the drama. That can be a sign of someone who is in control of the situation because they're causing it. On the flip side, some might also appear very anxious and hovering, but it's often coupled with being overly knowledgeable or ingratiating with staff. Trust your gut if a caregiver's effect doesn't match the scenario. Another thing, these caregivers are often not reassured by good news. If tests come back normal, they insist that the doctors missed something. They actually push for more tests or second opinions. They might frequently switch healthcare providers or EMS agencies. For example, if one hospital starts questioning the repeated illnesses, the caregiver may start taking the child to a different hospital further away and tell a whole new story. As EMS, you might pick up that the family just moved into your area or travels far for care without a clear reason. And any family history that seems tragic or odd is relevant. If you learn that a sibling of the patient died unexpectedly or also had mysterious illnesses, that's a red flag. While rare, there have been MBP cases where one child was harmed fatally, and then the abuse shifted to another child. Obviously, EMS wouldn't usually know that history on the fly, but if you do, take it seriously. Finally, keep your eyes open on scene. Sometimes you might actually spot evidence, say medications that don't fit the child's medical history or toxic substances within reach. You're not there to investigate like the police, but your scene size up could inadvertently catch something, maybe a bottle of Ipecac in mom's purse, which could be used to induce vomiting. If something seems strange, make note of it. Documentation in these cases is absolutely critical, because factitious disorders are all about deception. The more factual, objective information we record, the better it is for eventually uncovering the truth. So, what should you document? Everything. Start with what dispatch told you. Sometimes the 911 narrative is revealing. Maybe this is the third call this month, or the caller gave a very peculiar story. Document your scene observations. What did you see when you arrived? Was the patient doing something inconsistent with their reported symptoms? For example, you arrive and the supposedly paralyzed patient is seen walking to the door until they spot you. That should go in your narrative. If it's a child, note the environment. Were there any suspicious items around? Maybe you see a home health setup that seems beyond what the child actually needs, or multiple empty medication bottles. These details can be gold later. Document the patient's own words and the caregiver's statements. Use quotes, especially for anything that seems odd or telling. For instance, patient states, I just know I have cancer that the tests aren't finding. Or mother says, he always stops breathing right when I feed him. It's so strange. Writing their exact words can help professionals piece things together later. Also, note any requests they make, such as insisting you take them to a specific hospital out of the area. That could be because they're avoiding a facility that knows them. If they refuse to let you talk to other family or their regular doctor, document that refusal or obstruction. When you hand off at the hospital, be sure to tell the receiving nurse or doctor your concerns discreetly. Away from the patient, you might say, something about the history doesn't add up, or the mom's reaction was a bit off, FYI. They might have prior notes on this patient that confirm your suspicions, or your input might be the missing puzzle piece. Also, note in your report who you turned care over to at the hospital, and if you spoke to any authorities. In cases of suspected child abuse, which MBP is, we are legally mandated to report it. Usually, the ED staff will help facilitate contacting Child Protective Services, but if for some reason you're transporting and not going to an ED, say the child is already dead, a very difficult scenario, you would involve law enforcement directly. Always follow your local protocol, but make sure the appropriate agencies are notified. That could be CPS for kids, APS for dependent elders, and sometimes police if a crime is clearly committed. If you're not sure who to call, your supervisor or medical control can guide you. After the call, it's wise to debrief with your team or supervisor about it. Factitious cases can be emotionally frustrating. You may feel angry or manipulated. Talk it out professionally. Also, by flagging it to your system, next time there's a call for this patient, crews can be alerted to the history. Some EMS systems have frequent flyer notes or flags in their dispatch system for such patients, which can be helpful. The bottom line, your documentation is part of the evidence in uncovering factitious disorders. Be objective. Avoid saying, I think she was faking. Instead, just record what you saw and did. That factual approach is our best tool. Join me in the next part for some case studies and how we may handle them in the field. See you then?